Hi, welcome to Hopkins at Home. My name is Travis Reeder, and I am faculty at the Johns Hopkins Berman Institute of Bioethics, where I direct the Master of Bioethics program and spend most of my time thinking about the ethics and policy implications of pain, opioids, drug use, and America's drug overdose crisis. Today, I'm going to be chatting with Professor Hannah Pickard, and I will turn it over to her to briefly introduce herself.
Hi, everyone. Welcome. I'm Hannah Pickard. I'm a Bloomberg Distinguished Professor, cross-appointed to the Philosophy Department and the Berman Institute of Bioethics. And I work on a range of areas, predominantly the intersection of mental health, philosophy, and law. And one of the areas I work on is addiction. So just to give you an orientation for what the plan is today, some of you may have been with us for the first two sessions where both Travis and I each gave a talk. And our hope today is to bring themes from both those talks into conversation with each other and into conversation with all of you. So Travis is going to begin with a short presentation as a sort of shared foundation for that conversation. After that, I will make a few comments and start us off with a few questions. But throughout, we hope you'll send us comments and questions in the chat box. Those of you who were with us for the first two sessions may have questions left over for them that you'd like to ask. So please feel free to do that while Travis is speaking. And everyone else, please do ask questions as and when you have something you'd like to contribute. So without further ado, over to Travis to begin the short presentation for today.
Okay, great. So the explicit subject of today's chat is really taking philosophy and ethics, which is Hannah and I's areas of expertise, and applying it to America's drug overdose crisis. And so for those of you who've been with us for the whole course, you can kind of think about it segmented as my first talk was on pain and ethics of pain medicine, opioids, and kind of reasons for drug use, right? And then Hannah gave a talk on the philosophy of addiction, models of addiction, kind of the conceptual space of how we should think about these things. And now our big question is something that I think should appeal to everyone, which is trying to figure out how we can use some of these tools to actually think about solutions to the situation we find ourselves in America, that is to America's drug overdose crisis. So I'm going to walk us through just a few slides just to make sure everyone's on the same page. But I'm guessing a lot of this information is fairly old news for you. So hang in there because we hope this will be really dynamic and we can really just have a discussion for the majority of the time. All right, so let's talk about the scope of America's drug overdose crisis for just a minute. I feel like this was harder about 3 months ago because one of the things that I would do at the beginning of talks is I would try to say, everybody's heard of the opioid epidemic, or what I prefer to say, the drug overdose epidemic, because it's not only about opioids. But it's really hard to get a handle on the scale, right? Humans in general are really bad at numbers. And so I would give this prelude and say, we really need to understand the scale. Of course, now we're living through the coronavirus pandemic. And so numbers and scale are kind of all around us. But it's probably still a good idea because we're just as bad at big numbers when it comes to the coronavirus as we are when it comes to drug overdose. So let's talk a little bit about numbers and how much of an impact drugs have had on America in about the last 2.5 decades. All right, so the most recent year for which we have data is 2018. So let's talk about the number of deaths from a variety of causes in 2018. Drug overdoses altogether. So that's not only opioids, but also benzos, polysubstance use. So very often opioids, benzos, cocaine, and alcohol. So some subset of those, right? So deaths, drug overdose deaths from all substances, 67,000. And now focusing on opioids, nearly 70% of those involved in opioid. So about almost 47,000 people died from drug overdoses in America in 2018 that involved opioids. So here's the context part. Let's try to think about how many people that is. Only 40,000 people died from auto accidents in all of 2018. And 39,000 people died from guns as a result of any cause, homicide, injury, or accidental injury, or suicide. But now let's try to get a little bit bigger picture context, right? We are very comfortable thinking about AIDS as a real epidemic in this country. And so you go back to 1995, which is the worst year on record for AIDS deaths. And that year, 43,000 people died from AIDS. So more people died in 2018 from opioids alone than died from AIDS during its worst year. And now a very different context, but just because in America, we're very used to thinking about, well, especially folks of various generations are very used to thinking about how much the Vietnam War raised the political conversation in America because of the number of people, the number of Americans coming back dead, right? And so that led to various sorts of resistance movements. So the entire Vietnam War killed 58,200 Americans. So again, now, no, not just opioids, but think about all drug overdose. More people died in 2018 alone from drug overdose than died on the American side in the Vietnam War. Okay, but since we're in this moment where coronavirus is all that's ever on the news, let's understand that people are getting a little bit numb to big numbers. And so we're now at a place where 100,000 Americans have died from the coronavirus in just a few months. And so it might be a little bit hard to understand the scale as being really emergent. So I want to talk about the kind of entire arc of what I think of as the kind of opioid crisis, or the acute current American drug overdose crisis. And that starts in about 1999. So if you track the overdose deaths from 1999 until the last year on record, which is 2018, and count only the opioid related overdoses, so not all drug overdoses, which would be much higher, we get about 450,000 Americans dead in that time. So 500,000 people have died during this kind of acute phase of America's opioid epidemic from drug overdose. And a really, really important point about that is that every single one of those deaths was preventable, right? It's preventable in this very understandable sense that nobody has to die from an opioid overdose, because we actually have a miracle drug, like the closest thing we have to a miracle pharmaceutical, in the sense that Narcan, or generic naloxone, can reverse an overdose with zero side effects. And now we have it as a nasal spray so that anybody can carry it, and most people can go to their CVS and get it without a prescription because their state governors have written blanket prescriptions. So 450,000 people in the last 20 some years have died from opioid overdose. Okay, that's the scale. I think it's really important to understand how costly this has been. But now let's talk a little bit about the picture. So this is a very common graph to be shown. It was designed by the CDC. I'm going to show it twice during this presentation. The first one here, I'm going to focus on that purple line, because that purple line, the top line on the graph, is the overdose death rate. So deaths per 100,000 people in the population. The overdose death rate from prescription opioids. And what it shows is that we have a really good understanding of what sparked today's drug overdose crisis. Starting in the mid to late 90s, prescriptions drove a massive uptick in drug overdoses. It had remained stable for quite a long time. So between 1999 and about 2011, prescription overdose deaths quadrupled. It was a 400% increase during that decade and a little change. Now, I could put another graph up here to overlay it that is really striking, which is the volume prescription of opioids, which also raised exactly 400% between 1999 and 2010. So you have a perfect trend line match between the amount of opioids that we prescribed in the American healthcare system and the increase in the overdose death rates from prescription opioids in America. So this led to a really common narrative. That really common narrative is that prescription opioids sparked, kicked off an overdose epidemic in America. So now let's look at a whole bunch of literature from the peer-reviewed press, from popular media, just to get a sense of what sorts of reactions that has caused. So you go back to 2016, we had this prescription drug monitoring program. So PDMPs, they're called, are associated with sustained reductions in opioid prescribing by physicians. So this is kind of a evidence that PDMPs are working. They can reduce the number of prescriptions. Study finds 22% decrease in opioid prescriptions. This was published in 2018 to some fanfare because this is a celebratory note. We have now decreased our prescriptions by 22%. And isn't that a good thing, right? Reducing opioid prescribing rates in emergency medicine. This is something of a how-to guide. Doctors reduced opioid prescriptions after learning a patient overdosed. So this was a study that was done at the University of Southern California that showed that if you tell a doctor when their patient overdosed, they will predictably, on average, start to prescribe less. So this is taken as a kind of methodology how-to. If we start making sure that all doctors know when their patients overdose or die from overdose, they'll do better at prescribing fewer pills. Another sort of methodology how-to, feedback reduces opioid prescriptions. So telling doctors and other prescribers that you are giving too many prescriptions because your patients don't need all of them. And then the last one I use is from STAT, and that says, Trump wants to reduce opioid prescriptions by 1/3. We can start now. So this is another kind of rallying cry concerning how much better we can do about reducing our prescriptions, right? Okay, that's just a tiny little snapshot of the sort of narrative we got. And that sort of narrative was prescriptions caused today's drug overdose epidemic because we have this perfect trend line match between the volume of prescriptions we're putting out into the world. We're flooding the streets with this dangerous drug. A very predictable result is that a bunch of people are taking it and dying. And so the solution must be to cut off that supply, right? This is very logical in a sense. Glutton supply causes an epidemic. Stemming the supply is going to be the solution. So did we solve America's overdose epidemic? Hint, we did not. So now let's go back to that CDC graphic. Let's look more closely. So at the beginning, I just wanted to focus on what the CDC is now calling wave 1 of the overdose epidemic, which is this rise in prescription opioid overdose deaths. It was sustained, it was linear, it took a little bit over a decade. And about 2008, 2009, America was starting to come to the realization that we might have screwed this one up. There started to be calls for reduced prescribing. We had gone from this era in which, why did we prescribe all these opioids in the first place? Well, it's because doctors were told to take pain seriously. They were also told that opioids were safe and effective pain medications. So there had really been a decade, more like a decade and a half, that's sometimes called the decade of pain, where we trained clinicians to see pain as something that deserves treatment by the strongest pharmacology that we have, right? So we actually said to them, stop torturing your patients, right? Because a rallying cry of the pain advocacy movement was failure to treat pain constitutes torture by omission. It's a rallying cry. So we've been telling clinicians, stop torturing your patients. And what's really fascinating is if you talk to clinicians, or I don't know who all's in the audience, some of you may well be prescribers. If you are of a generation where you've lived through a couple of the phases here, you likely went through phases where if you were practicing before, say, 1990, you still were pretty suspicious of opioids. About the mid to late 90s, you started to be told, look, these are safe and effective medications, stop torturing your patients. So give them this medication. And so we see this uptick in prescribing that leads to an uptick in prescription overdose deaths. But by about 2008, 2009, the message starts changing. We see how bad things are getting. The epidemiology is starting to come in, which is pretty sad given how long this had been going on, right? There were whistleblowers as early as 2000. But we do finally start to see this, and the messaging changes. We start coming from the top down, policymakers, government officials, some folks in the media saying, oh boy, doctors, stop killing your patients. This drug is far too dangerous. Stop giving it out. And so the message starts changing, and we start telling our medical students and our residents different things. Instead of stop torturing your patients, we say stop killing your patients. Instead of saying stop, prescribe them whatever they need to get them out of pain, we're saying don't prescribe opioids. Opioids are far too dangerous. So a little after 2010, the message seems to have taken hold, and we start to curve down, we start to bend the curve down on the volume of prescription opioids. And right at about the same time, you see the curve bending down on the overdose death rate from prescription opioids. So now is our question. So did we solve it? Did we solve the overdose crisis? And the graph shows that the answer is clearly no, because right about this same time, we start getting concerned with prescription opioids. A couple other things are happening. One, in the years leading up to this, 2007, 2008, 2009, the streets of America start being flooded with very potent, very affordable heroin. And if you're interested in this story, Dan Quinones, who's a journalist, wrote the book Dreamland, really uncovered a pretty phenomenal level of detail of what was happening during this first decade of the new millennium. And it turns out we just got the expensive, kind of hard to access for a lot of people heroin that I knew when I was a kid, not that I knew personally, right, but that I was like acquainted with as part of the culture, was totally replaced with anybody can have access to heroin, kind of brought to your door by friendly drug dealers who don't carry guns. And it's really affordable and it's really good stuff. It's very, very pure, and all came from Mexico. And so it kind of replaced the cartels that were operating largely in big cities, went all the way across the country. Okay, so that happens in the middle end of this decade. And that really primes the pump, because right about then we're telling doctors to stop prescribing. Doctors are finally getting the message and they do stop prescribing. They start cutting their patients off. They start saying no. And so almost immediately overdose death rate goes up from heroin. And that continues to go up as we start to curb the supply of prescription opioid overdoses, curb the supply of prescription opioids and the number of prescription opioid overdoses. Okay, so basically what we have here is we have a transition in drug. As we start to cut the supply of prescription opioids, we have another supply that's very accessible. It happens to be illegal. It's part of the black market, but that black market is so accessible that it's not a huge cost to transition to it. And that transition happens really reliably, really predictably. And it turns out heroin's harder to dose than prescription opioids. It's more dangerous kind of in its packaging more than anything else. So heroin's not actually all that more dangerous than some prescription opioids in terms of raw potency. If you can get hydromorphone, which brand name is Dilaudid in the healthcare system, it's far more potent than heroin is, right? But when you get heroin, you don't get it from a pharmacy. It's not regulated. You don't have the purity rating. You don't know the exact dosing. And so dosing heroin is harder. And so it's riskier. You give this just a few years of transition to heroin, and pretty quickly something very predictable happens, which is that heroin starts to become contaminated. And I say this is predictable for the following reasons. There's something in economics called the Iron Law of Prohibition. The Iron Law of Prohibition says this. Basically, if you take a substance and you start policing the heck out of it, if you take an illegal substance or a substance that we've driven to the black market through criminalization, and you really focus the attention of law enforcement on it, well, now you've given the people who are operating in the space, you've given the people who are dealing the drugs, who are selling, really good incentive to make it more hideable, to make the profit margin bigger, right? Because you're going to be going after them. So here's what happened. As the heroin overdose epidemic overtook prescriptions, we start really producing these, we start really policing these heroin markets really aggressively. And so the drug dealers, who are very smart, said, well, we just need to cut it with really potent stuff so that we can package it smaller. We can make it easier to ship. We can make it easier to transmit, to get over borders. You can have less to get the same amount of high. If you get something that's very potent, you can cut it with a bunch of impurities, still sell it for the same profit with less product. And so we get the introduction of synthetic opioids, namely fentanyl, which I'm sure everyone's heard of, and its ultra potent chemical analogs like carfentanil. So if you don't already kind of know the information on this, so fentanyl is about 50 to 100 times more potent than morphine. If you've ever had morphine into the IV, I have. It's a wild experience, sends you straight to the moon. Fentanyl is 50 to 100 times more potent than that. What carfentanil is something that is another 100 times more potent than fentanyl. It's so potent that we don't dose it for humans. It's 10,000 times more potent than morphine. And so we use it for large mammals. It's used largely by veterinarians as a elephant tranquilizer, right? So carfentanil and other analogs are actually finding its way into the supply of heroin. And that is what this bottom line is. So within a few years of heroin becoming really popular, it gets more and more contaminated with fentanyl, and this synthetic opioid overdose crisis shoots through the roof. And that is what we're dealing with today, right? So now we're caught up. The prescription opioid overdose death, the prescription opioid overdoses definitely sparked the crisis that we're in. But we tried to stem the drug overdose crisis by curbing the supply of prescriptions. And we did not succeed in, smothering the entire drug overdose crisis. Instead, we seem to have succeeded in driving people from the licit market to the illicit market. Heroin is already harder to dose. It's already a riskier drug in terms of getting it into your system in a reliable way, but it becomes far, far, far more risky when you start contaminating it with the ultra potent chemical analogs of fentanyl, because now you don't have any idea what's in that needle or what you're sniffing. And so you might be getting the dose that you're used to, or you might be getting something way too strong. And that is resulting in the overdose crisis that we're seeing today. So there are definitely still prescription opioids on the street. The black market does still deal with diverted, is what law enforcement calls it, diverted prescriptions. People get them from their doctor and sell them on the street. That's definitely still the case, but the far more dominant risk right now is heroin contaminated with fentanyl, or as is often the case now, is just pure fentanyl. So there's our short history lesson that catches us up for today. So now we're kind of in the thick of it, looking at the details of America's drug overdose crisis. And I'm going to turn it over to Hannah to think about, how we want to start this conversation in terms of what this should tell us about addiction, or what addiction should tell us about how to deal with this crisis.
Okay, thank you so much, Travis. I really just want to make 3 comments to begin a discussion. The first is the way in which, in some sense, if you take the view of addiction that I presented in my session and that I know you share, where we really do need to think of people using drugs for reasons, even when they're addicted, you would expect that simply cutting off prescriptions couldn't possibly be the solution to the problem. Because if people use drugs for reasons, simply taking away the drug doesn't address why it is they're using it in the first place. And in some sense, that deeper understanding is, I think, so much a part of the picture that has been lost as we continue to focus on this drug or that drug and eradicating this drug or that drug. So we need to think about psychology, and we need to think about socioeconomic context in addition to the pharmacology of drugs. The second thing is just the kind of, this is more of a reflection really than a clear academic statement, is that we do tend to think of addiction and drugs in such black and white terms. So, we really think there's a problem, it has to do with drugs. If we can get rid of drugs, we will solve the problem. And there's something not only black and white, but slightly idealized and even moralistic about that. While I think actually it's time to be a little bit more real and pragmatic about the way actually drugs provide a lot of good for a lot of people. The reality is they've been a part of every human society practically that's ever existed and will continue to be so. And the solution is never simply to demonize drugs, but rather to have a more nuanced account that allows shades of gray to come into the picture. And so I think the third comment I just want to make to start discussion, and which leads to a question for you, is really sort of once we've sort of allowed that gray into the picture, and you think of drugs as part of culture, something that have benefits as well as costs. Indeed, the benefits are why people use them, because drugs do really positive things for people, like take away pain, but a range of other things as well. I think there's this really important question which has got lost from a lot of thinking, and which we both touched on in our sessions, which is the distinction between dependence and addiction. And so I think part of what happened in the medical community's response to the opioid epidemic is that they lost track of the way it might be perfectly appropriate for some people to be dependent on opioids, because if that prescription was stable and solving chronic pain, which they otherwise lived with and couldn't function well because of, there was a way in which that particular person's dependence was a good, not a bad. And the only problem for them came if there was not access to the opioids, which were keeping them functional and stable. And so there was a sort of knee-jerk reaction to think that someone who might merely be dependent was in fact addicted. And so, I guess for me, getting the distinction between dependence and addiction back into our thinking is really important. I see it fundamentally as drawn when the consequences of drug use actually are negative as opposed to, on balance, positive. That's what marks the distinction between transitioning from dependence to addiction. And I guess one question I've always had for you is whether, when you look back at that time when you were certainly dependent on opioids and struggling to come off them, the reality was that you were addicted, or the reality was that you were dependent and stuck in a system where the resources you needed to help you safely and effectively taper down and get off a pain medication that was serving a really important function for you, managing pain, just weren't available to you. So in some sense, that's not addiction. That's a problematic health system and a patient who is simply dependent.
Yeah, no, this is such a good question. And I will explain more why I think it's such a good question, because I think my own answers are sometimes kind of conflicted about this. Yeah, so like, let's get super clear about that distinction you're drawing, dependence and addiction. So Hannah gave, one way of really thinking about it that especially fits, the way she thinks about addiction, the way in the model she's articulated, which is that when the consequences, the cost of a drug go from being bearable for the good that you're getting to really being dominant, and you continue to take the drug anyway, right? So you're continuing to take the drug in the face of a bad cost benefit analysis. But I mean, there's a really interesting stuff to say about the difference between physical dependence and addiction, and we should make clear that this is just clearly a real distinction, no matter what anyone's model of addiction is. One way we know that is actually operates in two different brain processes, right? So from what we know about dependence, it operates in one brain system. So largely the opioid system that deals with what kind of effects you're getting from a drug in general. And then from what we know of addiction, it's operating in different brain systems, the reward and the motivation centers of the brain. They're kind of slowly changing in the way that our brain always changes as we develop habits and learn things, right? So one way to make sure everyone understands the difference between dependence and addiction is somebody becomes dependent on a drug when abrupt cessation induces withdrawal, right? And we know that you can become dependent on drug without becoming addicted, because a whole bunch of drugs that no one ever talks about in the addiction space cause routine dependence, right? So SSRIs and SNRIs, a bunch of depression and anxiety meds. Nobody talks about them having addiction liability because they don't induce euphoria. They don't kind of spark the reward center of the brain, and so they don't drive habit formation. But they're profoundly dependence forming. And so there's more and more literature coming out about what we might have done in creating a population of people who are really profoundly dependent on these drugs, and what happens when they run out of the ability to increase their drug. And so they have to go through withdrawal, because the withdrawal from a lot of different psych meds can be pretty terrible, right? So we know there's dependence without addiction. And then the thing that's more interesting, that maybe I'll kick back to you eventually, Hannah, since you've thought about addiction for so much of your career, is a lot of people think there's addiction without dependence, like gambling, sex, food, right? So you can have addiction because it's this mind process, this psychology process of pursuing rewards, even in the face of negative consequences. And so somebody who is addicted to gambling doesn't actually have the physiological dependence that comes from exogenous drugs being put into their body. So these dependence and addiction can kind of break apart in two different ways. Okay, that was a long prelude to make sure everyone's on the same page. So my experience, those who were in my talk last week know that I was put on opioids after a motorcycle accident, was on high and escalating doses for a couple of months, was giving really terrible advice on when to taper, and went through just awful life-limiting, suicide-making withdrawal. And so I wrote a book about it, gave a TED talk about it, because I think it's super important that doctors and other people know how bad this experience it is and what it could drive people to do. So here was my initial read that I still think is super important. My initial read was, in that experience, my prescribers immediately saw me go into withdrawal and be like, oh God, I don't know what to do with this. You need to go to pain medicine because your situation is complex. And they kicked me to pain medicine, and I went to the pain docs and like, oh God, I don't know what to do with this. I put people on opioids. I don't get them off. And I said, well, whose job is it to get me off opioids? And they said, addiction medicine. Go to a rehab clinic. And I had, in the moment, this response of addiction medicine. I don't have an addiction. It never once occurred to me, right? And to be honest, probably part of the reason is that I've been on SSRIs for a big chunk of my life. And so I know that withdrawal can just be a physiological feature of drugs. So it just never occurred to me that I was facing this other problem. And I still think that's a super important insight, because I think that was the vast majority of what was going on with me, right? If I had had a doctor who could carefully taper me down, partner with me, tell me what to expect, and mitigate as many of the symptoms as possible through things like a reasonable tapering schedule, I think I would have had almost no problems. It would have been uncomfortable. It would have sucked because withdrawal sucks, but I would have been fine. And that's not the mark of somebody who's dealing with more serious addiction, right? So the mark of someone who's dealing with more serious addiction is continuing to take drugs despite negative consequences. And I had a house full of drugs. I had pills of oxycodone, immediate release, and OxyContin sitting all over my house, usually one in my pocket, so that I didn't have to get up because I had a blown apart foot. And I didn't take it for a month while I was going through withdrawal. Not the mark of someone dealing with addiction, right? Here's the thing that I think is a little bit more interesting. As I've gone around and talked about this for the last several years, I do spend a lot of time with people in long-term recovery, and we talk about our experience, and they ask really fascinating questions. They say things like, so you never think about it? Like, it never calls to you? And my answer is, oh, well, sure it does. Opioids are awesome. They feel amazing. Of course I enjoyed it. And like, so you crave them sometimes, one might say? And I'm like, well, yeah, I guess. I mean, it's usually when life sucks a little bit. It's when I'm in pain. It's when I'm frustrated. It's when I'm overwhelmed, too much work, too many responsibilities. Like, huh. So when your life is going badly, you want to take drugs because you've had that experience and it made you feel better. But you never struggled with anything that felt anything like addiction. All right, so you're getting my point. One of the reasons I think it's really important to say that I didn't struggle with addiction in any kind of deep, meaningful sense is I think that makes light of the real struggle that so many people that I've worked with and talked with have gone through. This never threatened to burn down my life around me. I was incredibly privileged because I had this support system that carried me through, right? So I think it would be unfair to say that I struggled with something that's like what these other people have struggled with. But what it does is it makes me think that this is all on a spectrum. And so when I was writing my book, I had this fantastic conversation with a friend who's a psychiatrist, an addiction psychiatrist. And one of the points he made has formed a lot of my view about this moving forward, which is I wish we would stop talking about how pathological addiction is and start talking about how normal it is. And that has influenced everything I think about this topic, because what I now think about is how easy it would have been for me to transition that way if my life had been different, if it had been harder in various ways, if I had lacked the supports, if I hadn't had the infrastructure, if I had had so many privileges, right? Because it's a pretty easy thing to slip into. And I just happen to have been really, really fortunate, right? So that's what I think is fascinating, is to think about like addiction is probably, on my view, something like one end of a spectrum of learning behaviors and habit formation. And all of us typically fall somewhere in the middle, more towards one pole or the other. And I was just fortunate that I was kind of more towards the end that didn't struggle as much. That was a really long answer to your question.
Oh, no, it's a good answer to my question. And I guess I really like the idea that we have to stop pathologizing addiction so much. To go back to where you started, that's part of why a model like the one that I put forward and that you share, which focuses on continuing to do something despite the negative consequences, and which allows in behaviors, is so helpful. because we don't have that crux of the psychopharmacology of drugs to fall back on and think, oh, the problem is just the effect of the pill or the drug on the brain, because nothing like that is going on when we're looking at gambling or sex or other sorts of reckless, self-destructive things that people can get addicted to for one reason or another. And so it really helps normalize it and see it as on a continuum with other forms of behavior, as well as behavior around drugs, but which doesn't quite meet the threshold for addiction. And part of what happens is how exactly you draw the line, where exactly it is that all of a sudden we're tipping into the negative consequences really outweighing whatever good it is that someone gets from the drugs, becomes very gray and very relative to a person's individual life and values, right? And so, in some sense, as you emphasize, you were really lucky. There was a lot of other good stuff going on in your life, which meant that there was a pull away from the drugs. Many people don't have that. So I'm thinking now we should take a first question because it seems really relevant. So Sarah asks, after listening to your talks and reading some of your work, it seems as though the two of you largely agree in your understanding of addiction. On what points do you disagree? Why? To be really, that's a great question. It's something, Travis and I are always looking for things we disagree about. I think we both had this really funny experience of reading each other's work, and both of us are quite, we're a bit maverick within addiction research and theory, and recognizing someone who thought, broadly speaking, similarly, and being quite surprised and delighted by that. Because of course, the more people share your view, the more evidence you have that you might have worked things out right and got things right. So it was very welcome. But I actually don't know. I thought we might just disagree about dependence and addiction, but it doesn't sound like we do.
Interesting.
Yeah. Do you think you disagree?
So one thing that I should say is that you've thought about philosophy of addiction way longer than I have. Like, this has been a big part of your career. And so I think to the extent that we discover disagreements, it may well be that I start developing tracks that kind of break away in tiny different ways. But this really funny part of the experience was that I wrote my book largely before I discovered your work, kind of hastily added a footnote in the addiction chapter after I discovered your work when you came to Hopkins. And it was a funny experience of discovering kind of how much we matched, having come independently to a similar sort of view. The one thing about dependence, so I don't know there are any ways that we disagree, but there are different kind of points of emphasis maybe. And so I'll say them and you can tell me what you think. So one point about dependence and addiction is I do a lot, since I actually think about pain medicine ethics quite a bit. So I work with clinicians, and pain medicine is just deeply and profoundly broken in North America. And so I work with doctors trying to think about what's their responsibility to pain patients. And so I actually think a lot about patients who are dependent and not addicted. And I do a lot of the sort of work that Hannah described, which is arguing to the medical community that they've made a mistake insofar as they treat them as, risky or giving them liability because they have addiction, because, being stigmatized because they have addiction. Like, first off, let's just forget the stigma and then you don't have to worry about it, right? But also that it's just a totally different problem. They've just misunderstood what it is to be addressed in patients who have long-term dependence. But I do think that dependence is more problematic than we've given it kind of credibility for. And I don't think this actually conflicts with anything that you said, but it maybe indicates that cost benefit of when the costs and benefits kind of tip in different directions for patients who are dependent. I think we're getting more and more evidence that a lot of patients who we induce dependence in through kind of careless management of their medication, we've actually harmed by doing this. And we've harmed them in a couple of interesting ways. One is that dependence may well lead to the eventuality that they're worse off in the long term than they otherwise would be, because the medicine stops working for them and they can't know that without suffering through withdrawal, without going through this awful process of getting off, right? But it's also that not knowing is an interesting kind of harm, right? Because first personally, if someone gives you medication, you take it, it makes you feel better. They say you're gonna have to take more now, you take it and it makes you feel better. And you do that for 20 years, which we've done in North America with pain patients. The medication first personally has only ever made you better. And if we now say we've learned a lot about the pharmacology, and here's a really unfortunate fact, it may well be that you would be better off if you weren't on that medication. We can't know that unless we put you through this awful process of withdrawal, right? So there's a really hard problem of like how much we should value or disvalue the dependence forming property of drugs. And I think the similar sorts of things are true for SSRIs, for some anti-seizure meds that have been taken up as off-label use in different ways, right? We're just really comfortable putting people on medication that they can't get off without suffering because we don't think about the long-term implications of the drug, right?
Yeah.
So I don't know, what do you think about that?
So I feel, so one of the things Travis and I often talk about is the way I've lived in the UK the last 20 years, and he's of course American. So I'm finding my way in an American context, thinking about these things. And of course, for me, what that immediately brings to mind is the way, yes, here in America, drug pills really are the solution to everything. American pill prescribing is off the charts compared to the rest of the world. So when you have prescription practices where the thought is not something's wrong, let's get someone on a pill, but something's wrong, let's take a more holistic approach and see how we might help the person without immediately reverting to a pill, you probably get dependence in more select cases where there aren't other good options. And I suppose, in relation to that, I just always want to emphasize again and again and again, we need to think more about psychology when we're thinking about dependence, we're thinking about addiction. It's not just about, dependence is not just about getting hooked on a pill physically. For so many people, that pill has a certain kind of meaning for them, a psychological meaning, right? So cocaine is a drug, amphetamines in general are drugs, where there's no withdrawal syndrome. Nonetheless, people become dependent, presumably in a fundamentally psychological way. And that's really important. We shouldn't be minimizing that. But the solution is not to rejig our thinking about drugs. It's to think about how people find ways of managing pain and distress in their lives, and the way in which whatever's working for them then occupies a place which has such meaning and such importance. And that's part of what needs to be addressed. So,
yeah,
great
answer.
I think there are things there are problems that are specific to the way in which pain and health generally has been approached in America.
Yeah. Here, let me ask you one of these questions.
Okay.
So I think this is a great one for you. So this is from Katie, who I met when I was at my alma mater, Hanover College in Indiana. And one of the reasons I went is I went and spoke in her class, Confronting Poverty and Addiction in Southern Indiana. So it's a very cool class, team taught by a couple of very cool professors. And so the question is specifically, what are some ways in which we can fold your understandings of addiction into our work? And so the reason I thought it would be great to hear you say a few things about this, Hannah, is because there is a very particular, there's a very particular sort of poverty story is what I'm trying to think of like Southern Indiana. It's almost Appalachia, right? Southern Indiana, Ohio, Kentucky, right? And so I don't know what the entire demographic of the drug use and overdose epidemic looks like in Southern Indiana. But we can have a pretty good idea. Right down the road from where I went to college, Scott County, we had one of the biggest outbreaks of HIV in Midwest history because we had a major needle sharing epidemic when they discovered this drug Opana, which was oxymorphone. And so there's a lot of drug use in small town, pretty rural, fairly poor in terms of higher incidence of lower income, right? And pretty blue collar counties. And so I thought this would be an interesting point to talk about, like, reasons for taking drugs and the way they kind of fall out in different demographics. Yeah.
Okay. So with the caveat that, of course, this is not a population I know. I've worked in the UK and there are really important cultural differences always to think about. this seems to me sort of a classic place where if we just focus on the way drugs have a certain dependence profile and effect on the brain, which can, people think cause compulsive use, we miss the important bit of the story, which is what it is that drugs do for people when they live with both physical and psychological suffering in contexts where there are limited opportunities to find other ways of managing that suffering or other goods in life. So, poverty is a burden not only because of the way it means you can't get food on the table, you worry about your children, you may suffer yourself from starvation and a sense of deprivation, but also because of the way it situates you in relation to others in ways that are psychologically potentially humiliating and impactful. So it has this multiple ways in which people suffer when they're in contexts of poverty that it's hard to escape from. And one of the things we know about drugs, right, is that they offer escape. That's what they do. When you're suffering physically or psychologically, they make it better for that brief period. So, the idea that what we need to be thinking about in a context like that is lifting people up out of poverty so there is less suffering in their lives, which drugs can then, as it were, solve in the short term, is the first absolutely clear point of contact. I guess the second thing that, as you know, I've become really interested in is thinking about the way in which when someone has been an addict for a long time and doesn't feel that they have other options or ways out, that addict identity can really become part of their sense of self. And insofar as this is a question about how to help people think about engaging with people who are struggling with addiction in these communities, I guess I really would want to say don't shy away from thinking and asking people about the way in which their addiction might be part of their sense of who they are. Because I think we're kind of scared to ask that. We think of addiction as so shaming and stigmatizing that asking someone about the way in which their drug use may be wrapped up in their own identity and sense of who they are feels like you could be condemning or criticizing them. But actually, when it's done with care and compassion, it can be a bit of a relief because it allows people to talk about something which is quite hidden and not easy for them to bring up, even though potentially very meaningful and important to them. So I guess I feel like alongside thinking about the way in which drugs help deal with suffering, so the obvious first thing to do is alleviate suffering, we also need to think about the way they then can become part of a person's identity so that it can be harder for them, even if you do give them other options, to take them because those options aren't consonant with their sense of who they are, having become an addict and lived in that way and in those communities for a long time. So I suppose that's the other thought I have.
Yeah, I mean, one of the things that I say a lot when I get asked about, various communities that are having a hard time, right, is I always ask, so if you believe that people take drugs for reasons, which I do, which you do,
Yeah.
can we identify reasons that seem to be more operative in that space than others, right? And there's a kind of self-medication model of addiction that tries to look for, is everybody just using it as a medicine, which might be brushing with too broad of a stroke. But you think about, what do opioids do? They're analgesics, they provide pain relief. They're euphorics, they give joy, they give some amount of euphoria, relief, comfort, right?
Mhm.
And they're sedatives. They help you relax. They slow down your breathing. They give you space, right? I mean, those are really there are really good reasons to seek out all of those states, right?
They're
And
hugely
so
valuable states.
they're
Everybody is rational for wanting them, right?
exactly. And so, you think just about the analgesic component, right? You think about, look, they relieve physical suffering, but they also relieve emotional suffering. And so if you have a community where there's obvious endemic suffering, there's a really good reason to take these drugs. Doesn't mean there's the most reason. It certainly doesn't mean people should, but it's really understandable that people take drugs that relieve suffering if they're faced with a lot of suffering. And so the thing that I've said that seems to surprise a lot of people in talks is I say, there are communities where it's way easier to get heroin than it is to get, good health care for your back pain. And so you could actually imagine somebody taking heroin because they live in agony for their back pain. Like nobody would take heroin for their back pain. Are you kidding?
Absolutely.
Heroin is like OxyContin. It's a pretty good drug for short-term acute pain relief. If it's all I had access to, and I know very, very well what really severe acute pain feels like, if it's all I had access to and I was facing the kind of pain that I still remember facing after being in a motorcycle accident, you better believe I would take it, right? Because it does the same thing that these other drugs that we feel more comfortable saying does, which is it provides immediate pain relief.
Yeah, I thought you were going to say that they take heroin not because they can't get other pain relief, but because they can't get a job. It's easier to get heroin than it is to get a job. So,
well, there's that, yes.
right. Well, that's really important because there's a way in which a life that feels to you to have purpose and meaning. In the addiction literature, it's sometimes called having a stake in a conventional life. I don't really like the term conventional, but meaningful life seems to me a perfectly good way to think about this, is so important in helping people not become addicted or get themselves out of addiction. And one of the things that's, when we're thinking about poor communities and underprivileged communities, that's so important, is that it's not typically like if you manage to stop drugs, everything else in your life sorts out. So it's not like you come off drugs and you have a job and your relationships are repaired and you have new educational opportunities, they're waiting at your doorstep. Typically, all the reasons you are suffering and all of the losses and lacks in your life are still there and present. So, there's not a lot of incentive to come off drugs in that kind of context unless we help people have more options in those contexts.
Yeah, I mean, I'll say just quickly, I find it very telling that when I remember wanting to be off opioids after my motorcycle accident, when I remember the form of that desire, why did I want to be off opioids? The primary reasons were I couldn't father or be a good partner when I was on opioids.
Yep.
And I couldn't do my job when I was on opioids, right? I basically was spaced out 24/7, so either spaced out or asleep, and I was missing my baby girl growing up. I wasn't helping. I wasn't being a good, domestic partner, and I couldn't do my job. I couldn't be a professor, and those are three hugely valuable things to me, hugely valuable components of my identity. And so a kind of haunting thought is, what happens if you don't have them? What would have happened to me if I didn't have them? Because those were the drivers, right? Those were the motivations.
Good. Yeah. So I'm just looking now at our chat
Yes.
box and thinking, so in ways I think we've already talked a bit about Annie's question, which flows really nicely, which is which populations of people see a disproportionate number of overdoses. The answer is people who come from socioeconomically underprivileged backgrounds and typically have comorbid mental health problems. And
there has been a shift, though. I mean, so it's interesting that in the North American context, in particular, the opioid epidemic found niches, right? Yes. And so, the silent epidemic that we didn't talk about for 4 decades or whatever was when it was largely affecting minority communities in urban centers. And so Baltimore has had a heroin epidemic for a very long time that wasn't getting any attention. It then moved in the 90s, early 2000s, largely to small towns and rural areas where it disproportionately affected white people who were very poor, who had relatively few opportunities. And that started to kind of gaining traction, although it may well be the case that it still wouldn't have gotten to the point of getting all of the attention if it hadn't snuck out of Appalachia, if it hadn't snuck out of the small towns and eventually gotten into the suburbs, right? Because once heroin was everywhere, you had lots of other reasons to take it. So not just relieving suffering, but because it makes you feel great. And so there are all sorts of people in the suburbs who also want to feel good, right? And that's what started happening towards the latter part of the early 2000s.
Yeah, absolutely. But it sort of speaks to the one-size-fits-all approach won't work, which is in the question, which is absolutely apt, right? So
definitely,
always. And in ways, this is just a principle of basic good medical care. You always need to tailor the care to the individual and their context, right? So this is true when dealing with addiction as much as anything. You need to figure out what's going on with that particular patient, which means they're continuing to use despite negative consequences, and tailor the intervention to help them. So really, we need to get far more precise and specific in how we're engaging with people and thinking about their problems and offering to help.
Totally.
Yeah.
So there's this interesting question about, is the opioid epidemic unique? You probably have a one good perspective because you know that it's definitely different from where you were living. I can say something about other countries if you want, but yeah, why don't you say a little bit about your kind of comparative experience?
So it certainly is unique in the sense that in the UK, insofar as there's a growing and increasing problem with heroin and fentanyl, it wasn't caused by the kind of overprescribing that was the genesis of that in the US. It's caused much more by the flooding of those markets because of the availability of the drugs that's now there. And again, the kind of contextual and psychological factors, which mean that these drugs have real value to people. They're available and they have real value. Um, but I guess one of the things that's genuinely different in the UK is just the cultural attitude towards drugs and drug use is different, and so and similarly there is a single public, nationally organized public health system to deliver interventions and try to think about how systematically to give the best kind of care, and so the way in which there's an epidemic or the way in which drugs impact on the population is viewed very differently and also dealt with very differently than in the US. I think there's some fear in other countries that the US is exporting its opioid problem at present. Hopefully not, but
Yeah. So I'll say a little bit more about other countries. I mean, is it unique? I think the answer has to be yes. I mean, the United States is in really serious trouble, but is it, radically different from every other single country? No. I usually talk about the drug overdose epidemic in North America because we have definitely exported it to Canada. And so, I do a decent amount of work in Canada now, which surprised me at first because I'm like most Americans and was very America centric, right? So when I first started getting invitations to Canada, I had to research their epidemic, and it turns out they're about 3 to 4 years behind us on the trend lines, but on the exact same trend line. So on a given year, they're pretty close. And it looks like the reasons were probably similar. They didn't collect as good epidemiological data going back as far as we did. So we don't have the 1995 to present story. But one of the things you'll hear Canadian doctors say quite a bit is, look, you all gave us the same advertising pitch, right? We all got that same thing from you. But it really took off for them with heroin and illicit fentanyl. Fentanyl is a major, major problem in Canada. And it's distressing because they're much better at addiction treatment. They have a nationalized healthcare system and they have harm reduction to a greater extent than we do. And they're still not kind of bending the curve on this, which there are, interesting reasons to try to figure out why that is. The other case that's fascinating is to try to figure out where things did not go the way that they came with America. And so Germany is a really fascinating case study because a lot of folks want to say supply may not be the problem. So if they listen to Hannah and me rant for a while, then fine, supply is not the only problem, but it's got to be a problem. Look at the North American history. The last 2 times that we, jammed a glut of drug supply into the streets, it caused an overdose epidemic, right? Well, turns out that the second highest per capita prescriber of opioids in the world is Germany. And they don't have a significant drug overdose problem, and it hasn't changed in 4 decades. Mm-hmm. So they've gone through a period where they have become a significantly higher prescriber. They still do not have the kind of pill for every pain attitude that we do. They still, there are all sorts of stories of people going to Europe and like, you're going to make me go through this surgery without any opioids, right? That still happens. But they prescribe much higher than almost any country except us. And it hasn't caused major public health problems. And so there's a really good research program to be done there, trying to figure out, pretty obvious hypotheses, right? They've got a nationalized healthcare system. They take care of their people. There's much less endemic poverty, right? So all of the things that we've been talking about that give people reasons to take drugs, many of them are minimized there, but more data to be collected.
Right. It does take us on to what may be our last question, which is about harm reduction. Prohibition is not working. Should we somehow enable managed opioid use? The answer is yes.
Yes.
Clearly and unequivocally, we need to have a harm reduction approach. That's the only realistic thing to do. Lives depend on it. Personally, I would also add, in conjunction with that, that we need to decriminalize drug use, that the criminal law is the morally wrong tool to use to deal with drugs in any society. It's not only not effective, it's not legitimate as a use of criminal law. So that needs, in my view, to be part and parcel of harm reduction, is to demoralize and decriminalize use. But the clean answer to the harm reduction question is absolutely 100% as much as possible. Let's save lives.
Yeah, exactly right. And we're so far from that in the US that we have to, attack the next thing next. But we don't even have safe consumption spaces, or what we're now calling overdose reversal sites. So places where you can go and use or inject your own drugs that you bought elsewhere. We haven't even gotten to the place where we can accept those in society yet. So baby steps. But yeah, the end of that chain of reasoning is decriminalization and managed use, for sure.
And together with that, we have to end, but Kristen's thought of a caring relationships making a positive difference. Yes, it's a very different attitude to take to people who use drugs, rather than stigmatize, criminalize, condemn them, to think about them as people to try to care for and take care of, and to use that as a basis of tailored, positive patient intervention. So we may be a long way from it, but it's where we should be going.
Beautifully said. That seems like a great place to end. It's 1:00. Thank you all for joining us.
So
I don't know who you are. I can't see you or speaking into space, but thank you for being there, presumably. Take care.
Bye-bye.